Thank you for joining us today for our training, Person-Centered Care in Nursing Facilities, How to Make It Work, Part 2, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and we truly appreciate each of you for joining us today. And now, I am happy to introduce our presenter for today, Ms. Diana Padilla. Diana has more than 24 years of experience in behavioral health industry. Her vast experience includes service provision to diverse communities with substance use, HIV, HCV, trauma and stress, and other psychosocial conditions. Currently, Diana is a senior staff trainer for the Northeast and Caribbean Addiction Technology Transfer Center. I'll now turn it over to Diana to begin the presentation. Thank you.
Thank you, Nikki, and thank you, Derek. And thanks to everyone here for for taking time out of your very busy schedules. And I thought that it would be appropriate to just begin to this discussion. And I do encourage discussion. So please, if you have comments or questions, please put it in the chat box. I have a nice habit of checking in while presenting. And so I thought I'd start with this phrase that came from an article written by Dr. Michael Sakaris. He's an oncologist in the University of Miami. And what he spoke to was what's meaningful to our patients trumps anything medical that we can offer. And so in terms of folks who are residents who are in our care and are going through their healthcare issues and trying to recuperate and benefiting from all the clinical approaches and all the supports that you're giving, many times what can benefit a particular resident can be that relationship they can have with the nursing home staff. And so this particular experience, as referred to here by Dr. Sakaris, is really speaking to how in healthcare, it's more than just the clinical processes. And so residential nursing home care, which is more than the clinical supports that you folks provide, it includes and should consider how you engage the residents and build that collaborative interaction, that type of relationship that can be very meaningful and supportive to those residents and enhance their outcomes, their care outcomes. And so to speak to that a little bit more in terms of person-centered care, the person-centered care is really the basis of the philosophy and the mission statements that many healthcare institutions have adapted and tried to adhere to. It's not necessarily a new phenomenon, but you folks already focus on providing services very specific and tailored to the needs of every individual that comes into your care. And so the Centers for Medicare and Medicaid Services say that the integrated healthcare services are delivered in a setting and manner that is responsive to individuals and their goals and values and preferences. That's in a system that supports good provider-patient communication. So that's speaking to the nursing home staff opportunities of initiating rapport and engaging in a relationship in a collaborative relationship with a resident to help empower them to receive care. And where receiving care and providers can make the most effective care plans together. And so actually including the input and the perceptions of the resident. And so with respect and empathy, person-centered care is also an approach that nursing home staff can use to engage residents in all aspects of their wellness. And so using person-centered care, nursing home staff can have these collaborative, engaging conversations regarding all aspects of the care or wellness process for any given resident, and both in the care plan at the facility, whether it's acute or long-term care, and certainly also engaging in opportunities to provide education around health education around medication adherence, even risky levels of substance use, different issues that can affect the individual's healthcare even after they leave the facility. And so being able to have that type of rapport with an individual, with a resident, to be able to have that kind of conversation where you can build that receptivity to the information you can convey them so they can play an active part in their process can be so um, essential, can be critical to those increased rates of successful health outcomes for that given resident. And so, one of the things is we've been, it's not like it's a new philosophy for your facilities. This has been something that has been spoken to for the last many years. We've seen more and more um, healthcare leadership surveys, researches, and as speaking to the importance and the benefits of taking a person-centered care approach. And so person-centered care approaches is also not just shows significant improvements in residents' levels in terms of, say, it can improve their levels of boredom or helplessness when they're in the resident care facility, but it has also shown to show a certain an elevated sense of job satisfaction for the nursing home staff as well. And so let's look at the current landscape of what residential care looks like for nursing home facilities. And so nursing home care provides that critical comprehensive care, which I just spoke to, which you are all so proficient at doing with, well, and you can do it very tailored for anyone who has, whether it's acute or long-term health conditions. And so the person-centered care aspect also is, particularly in nursing home care, and speaks to how the services are coordinated to meet the individual needs. So depending on the diagnosis and the medical conditions and the appropriate level of care and the appropriate interventions and the clinical processes involved, all that is tailored per resident that you have in your care. And so one of the things we want to consider is who are the folks, who is the resident um, recipients that are benefiting from all that care that you give them in the facilities. So one of the more recent research studies have shown that in 2023, amongst long-term home care residents, nursing home residents rather, a predominant amount were people who were over 65 years of age. Maybe just under 17% were under the age of 65. In terms of what they've been seeing, what the research is showing, what we've been seeing coming into the nursing home facilities, we're seeing that more Medicare recipients have with opioid use disorders have entered the nursing home care facilities and at higher rates compared to non-substance related hospitalizations. And in the context of how opioid use disorder has really increased over the last recent years, this is unusually high for folks who are from the older cohort, but that's what we've been seeing. So according to the Center for Disease Prevention and Control, alcohol-related deaths for adults increased over 18% up to in 2020. And many of those deaths also were from the same cohort. A lot of the deaths that have been involving overdoses, particularly those laced with fentanyl and synthetic opioids, have increased by 53% in the same year. And so we're seeing patterns that we can be preventive with. And there's opportunities here to be able to engage individuals, to have conversations about what they are, how they're using substances, and how that may be mitigating not just their health issues, but also the care plans you have in place. So one of the things that can be helpful is just to remind ourselves, some of this you already know, which is a substance use disorder is considered, it's perceived, particularly from a medical model perspective, a brain disease. So the diagnosis for substance use disorder is based on an 11-point criteria of several aspects of related impacts, including the cluster of cognitive, behavioral, and physiological symptoms that indicate continued use of the substance despite significant substance-related problems. It also has an impact on relationship and also can have an impact in a variety of different ways. And this is very specific to each and every individual who may meet the substance use disorder criteria. What is interesting also is that the stigma and the shame that's associated with addiction is part of the negative perceptions toward people with substance use disorders. Some perceptions are like that, perceiving people with substance use disorder as being weak or immoral, or thinking that they are just willfully trying to just have a good time despite responsibility, despite relationships, despite the communities. And so, but really understanding that addiction impairs the brain in many ways. The neurological processes do get rewired, and those pathways of the brain diminishes the capacity of the person to be able to stop using substances on their own. And that's at a point where someone who is at a substance use disorder level where they are using despite their desire not to use. The capacity of the individual and the rewired neurological functions are such that what leads this, the say what we are often referring to as the drug-seeking behavior, it's really about how that brain is starting to it has started to function very differently. And so oftentimes the perception of someone with a substance use disorder, it's that they can stop on their own if they really wanted to, and it becomes a moral perspective. And that's only in light of not having information that's fundamental to the understanding of how substance use disorders works. And and substance use disorder is at the extreme end of the severity of the spectrum of substance use because we have different levels of substance use or consumption. And it could be an at-risk level that can be impacting their health. It could be misusing and not and unwittingly affecting their health. And so we can make a difference when we use certain engagement approaches to be able to provide that kind of information. So some of the staff-related barriers to addressing substance use in resident care has to do with some of the trends. It has a lot to do with the absence of the formal and substance use information or education on it. There was one study that was conducted with nursing home staff and found that there were inconsistencies regarding substance use knowledge and uninformed protocols. And the truth is that there's a significant impact on resident health outcomes. And when we are not incorporating substance use within the provision of the different services and the different clinical treatments that we are providing. So it can lead to staff to maybe perhaps the staff not being prepared, or maybe staff perceptions on addiction, or maybe an overall lack of resources. Just the fact that you're here, it says a lot about the fact that you're looking to augment some of the work in the health and the clinical care that you are already providing. And so while you're all typically and understandably focused on the medical and health conditions of that individual, there can be other mitigating factors that are substance use related that might impact on all that, on how the healthcare plan, how it results in its outcomes. And so with that in mind, I want to mention that sometimes addressing substance use among residents can really be about really visiting and looking at the policies and the protocols in a particular setting, and being able to inform it and perhaps adapt it or evolve it to be informed from a substance use perspective. We focus on here on staff knowledge and perceptions of substance use that can make it difficult for residents to understand that substance use behaviors can put them at a higher health risk and further diminish. And also, sometimes when we think about how it can further diminish the interaction between you and that resident. And so all of this is really critical to be able to evolve and just enhance the care that you are providing. So in terms of challenges to addressing substance use in nursing facilities, so some of the things that we found is that nursing home residents may not be screening for substance use. And that's not necessarily a standard process across all nursing home facilities, but it may be something to consider. There are some surveys that found that substance use symptoms in older adults may be misinterpreted as age-related conditions. How many times we understood that a particular medication that's being provided to a resident in care may have adverse effects in terms of, say, gastric issues or stomach ailments. And it might actually, instead of thinking that it might automatically be related to adjusting to a new medication, it could be that there may be substance use may be part of that. We don't know if we don't ask. And so really sometimes understanding how substance use can impact an individual can be somewhat elusive. So adults with substance use disorders and those who meet the criteria at that level, you know, sometimes they are denied admission to residential nursing home care, but and that has a lot to do with organizational practices that may not necessarily be informed by substance use and may not necessarily have the capacity to be able to um, address the healthcare and the potential substance use impact. You know, studies have found that some nursing home facilities are not very equipped for supporting persons with, say, an opioid use disorder. So if someone comes into your care, has an opioid use disorder, they happen to be on, say, methadone, a medication for opioid use disorder, MOUD, those that are admitted for care may have either their medication stop, which is something that they typically are required to obtain on a daily basis and in person. Sometimes organizations uh, may not have the capacity or the opportunities for staff to accompany that person to go in person to get their, say, their daily dosage of methadone. So consequently, it increases the risk of overdose for when an individual does leave the facility, not being able to get the required medication on site. So being able to understand how that can apply, how that can have implications for care and certainly influence, protocols, that would be something to consider. And so lack of staff support, lack of knowledge, and a lot of times, this is it seems to be, I've spoken to some of my colleagues who do work in nursing home facilities, and one of the things they do kind of stress, and there was a few of them kind of theming this out, is that a lot of nursing homes do not routinely teach about substance use disorder. So when you're not teaching about that aspect, because it's not necessarily maybe perhaps it's not necessarily considered about the medical focus that you all engage in, it certainly has become part of it. And not having that information can just help you just focus on the medical aspects, but we might be influenced by other environmental cues, if you will. And so there was I'm really big about research and studies and different and current information that's available to inform practice. And so what we've seen is how stigma and bias can influence how we interact and how our perceptions of someone who may have a substance use disorder. And so again, I want to mention that we don't always have that fundamental understanding of substance use or risky consumption of substance use, because they're not, just because someone doesn't have a substance use disorder doesn't mean that their health is not being affected by their level of consumption. And so whether it's misuse, it can certainly influence on how we engage. So research indicates that nursing home staff perceptions of people with substance use disorders can include, and there's been a few studies, residents with substance use disorder may be considered that they're more time intensive. And in light of not having that extra information of substance use, so the perceptions may be that they are more time intensive and more effort needs, and then more effort is needed to work with residents that have potential substance use disorder or substance use related problems. And particularly in light of all that busy schedules and the heavy workloads that you folks kind of engage in, it's almost understandable why sometimes we can see this in how research captures this, and in light of not having that other information. So residents with substance use history sometimes are considered to be manipulative and aggressive. And when we understand maybe the dynamics of a person's world, including how substances may be impacting or the lack of substances may be impacted, that might be perceived this way. There are times where residents have been considered like unpredictable, challenging, or deceptive. You know, nursing home staff, as well as any other discipline that works to address community needs, are driven by the focus of their profession. And that's the reality. And so nursing home staff use a health-oriented focus and not and you would benefit from understanding of how the intersecting impacts of substance use can actually help you do a more informed approach and tailored approach in terms of a particular resident's healthcare. So, so sometimes, so I want to come from here, and sometimes there are times when we don't have information, certain other things may be what we start to kind of consider, and not necessarily intentionally. So I'm going to ask folks, how many folks here, I'm going to come off the camera for a second. I'm going to ask how many folks here are able. Okay, so I see the chat box, and a lot of you are able to respond in the chat box. So if you don't mind, let's do a little experiment here, and you let me know. I'm going to bring up a word. I'm going to ask you to put in the chat box what word comes up for you to complete a very, very brief statement. Since you have access, this can be an interesting opportunity. So let's try this. So I'm going to put in night and what comes up for you there? What word would you come up with? Put that in the chat box, please. Okay. Excellent. Thank you, everyone. Okay, let's try this again. How about this one? Young and? Thank you, everyone. Thank you so much. I love that. Young and free, young and younger. I appreciate the one. Thank you, Shannon. Young and restless. And but a lot of people did respond to old. Thank you for that. So you can consider perhaps why I was doing this. So what happens is a certain word came up for you, a word that you seem to associate with the first two words that I present. And that's what you wrote to. So thank you everyone for your participation. And the interesting thing about that is that that sometimes we don't necessarily have to think about what we're going to do. Some things happen like automatically. And it's that part of our brain that's really essential to sometimes when we are in dangerous situations where we don't have 5-10 minutes to process the pros and cons of a given situation to make an informed decision. We don't necessarily have that. So things can't come up automatically because we know we have certain information stored in our minds, in our brains, and our neurological processes are built in such a way that we can capture or grab the information that we need in a moment's notice. So you always find the night and day or night and old, young and old, different words that speak to what you associate with that. And so here's my point, and let me just bring it to you to here. Yeah, Nakisha, I picked up on the young and dumb. So I wanted to bring this to here. So just to make this really relevant to why you're here. So there's some studies about behavioral health bias that has spoken to how mental health and substance use disorder professionals, and these are folks who actually work with this issue, how many times they're more likely to judge or agree to disciplinary action towards a person, a patient, a client, even a resident, when they're referred to with negative connotations, such as a substance abuser, as opposed to a person with a substance use disorder. The point there is that a lot of times when we don't have some basic information in how substance use relates, other influences from the environment, other influences from other places can actually impact on how we perceive someone with a substance use disorder, and it can also impact how we do engage or interact with a given individual. And many people who are uninformed are more punitive in their perspectives with people around people with substance use disorders. So mental health practitioners were less likely to believe that an individual deserved treatment when they were referred to as a substance abuser, as if to say that substance abuse is a willful act, a judgmental reference that speaks to the person's desire to want to consciously use substances, which is not the case. A person who has a substance use disorder at that point, as I referred to earlier, their neurological processes diminishes their capacity to be able to just engage and stop a certain behavior, like say anyone else who doesn't have that same issue. And so the idea is that sometimes that bias that influences the environment, that influences a lot of people who from the community or society at large that does not work in the profession that you do, in the disciplines that you do, a lot of times that can influence us, even if we do know better or more informed. And so sometimes that bias kind of results in stereotypical and differential treatment when we engage individuals. And so in lieu of not having that information, it can actually result in microaggressions towards individuals or stereotypical threats, experienced by the individuals. And so what we want to consider is that, and this was like a really interesting article that was written about the reality is all moments of human decision making are susceptible to the influence of implicit bias. All of us. I do a lot of work around this topic, and I am just as influenced as any one of you, very proficient, amazingly hardworking people. And so, because of the context of our environment, because look at the atmosphere where we live in, look at how we have to navigate through our world within the context of the outside world, our environment. So just imagine many of our residents who come in with challenges about coming to terms, say, with age-related issues, with medical issues, and other things that may be happening in their world. And so we can be impacted, and our implicit bias may come up. And bias really comes from, listen, if you are able to say you have a favorite color and there's a color you don't like, there's a favorite music you like, there's certain movies you don't like, that's those um those preferences have the other side of it is a bias. Sometimes the neurological processes get caught up and gets influenced by what environments, what the society says. And so considering that we only really internalize about 50 bits of information per second on a conscious level, simultaneously integrating 11,000 bits of information per second unconsciously. And that's throughout our existence. And so, of course, bias may come up every once in a while. It depends on what influences you have in your environment. And so what we want to talk about here is whether it's positive or negative, those biases can have grave effects on all outcomes of and all sectors of our society. So we talk about how this happens in an automatic way. Perhaps many of your responses were automatic. I don't want to make any assumptions, but we do have a part of our brain that overrides our conscious intentions of impartiality. You folks are doing the jobs that you do because you like helping and working with people. And in spite of that, the environment can influence us in our perceptions in different ways. We know that the limbic system sorts out information and categorizes information, and in a moment's notice, certain information will be available. If you are crossing the street and the light changes halfway through, and you have to really get a move on because now the traffic is coming, and if you go to the same pace that you were going at before the light change, you will get hurt. You're not going to think about it. You're going to automatically just jump out the way. So your brain grabs the information it needs to survive in the moment. It's those processes that get influenced subconsciously by the environment that we exist in. And so we want to call that out. The way we can do that is we can build awareness. And so the way so the great thing about that is because we're such malleable creatures, once educated on the science of implicit bias, we can impact those biases. Doesn't mean we're going to get rid of them because we always have a preference for some things and not for others. But when we build awareness about our own self and how we think about certain things, we can certainly start to mitigate the impact of potential bias. And so our developing conscious bias and attitudes can be unlearned. The same way we were conditioned for a great many years to think certain ways, to believe in certain things, certain philosophies, we can certainly look to unlearn perhaps some societal attributions or societal influence biases and be able to change that with a more positive perspective and understand how we can move forward with an equity lens. And so if you have any questions, please feel free to ask in the chat and I will respond. And so one of the things we could do is to identify our own implicit bias. So recognize that it is in us because as long as we're human, we will have a preference for one thing and not another. That's a bias. And so through our lifetime of conditioning and the experiences that have developed, our negative attitudes and stereotypes toward people, particularly of people of color or people with substance use disorders or people with disabilities, many times these are the communities that tend to have those stereotypical biases against them. And so knowing that implicit bias affects decision making, even if you don't set out intentionally to discriminate against anyone, what we want to do is if we raise awareness, we are better able to not act on that, to better able to condition ourselves to rechannel our energy and our perspectives differently. And if you wanted to, we can always, we can take measures to identify and assess our own implicit bias and, and consider how it may be how it might influence how it is that we engage residents in our care. And so some of the and how we make decisions and how we interact. And do we interact differently with some residents as opposed to other residents? You know, there's certain things that we can do just to check in on ourselves. This is not for supervisors, this is not for colleagues, this is just for us as professionals to look, let me see what I do. Let me take a step back. And I know every once in a while you folks can use taking a step back from your schedules, you know, but it would benefit you to kind of just take a look. How do you interact with different people? Is it the same as your energy totally focused on them, or is it different for each individual? Those can be telltale signs that can be helpful for us. And then depending on what kind of day you're having, if you're overwhelmed. So in high stress environments, we tend to be more at risk to act out on a particular bias. And so one of the things that can be so helpful is taking an approach, and this is foundational to person-centered care, is the culture of humility. The culture of humility as a concept, I'm going to tell you how it is as a practice. Culture of humility, the term was coined back in the late 70s. And so culture of humility involves acknowledging oneself as a learner. And so as proficient and as skillful as nursing home staff are, what we do know is that you're good at what you do. And sometimes what we don't always know is that we don't always know that person. Despite the fact that we see some common issues, and we've been seeing it for years, we don't necessarily know how that person perceives their world, their situation, and what makes them move forward or move in any kind of a way. And so it's pretty important for culture humility, it's pretty important for us to understand the other person's perspective. So humility really has to do with not being it's not proud or arrogant, it's really just or courteously respectful. It's more about being comfortable with the idea that you don't know that individual yet. You have a lot of experience under your belt, but you don't know that individual yet. And when you get to know the individual, you're able to use all that expertise you bring according to their needs. And culture has to do with what's their perspective, what's their belief system. Race and ethnicity can impact, gender issues or non-binary issues can impact, but the reality is every individual you work with, every resident has their own cultural perspective. They have their own ways of communicating, their own ideas, they have their own reasons for uh, for their personal philosophies and how that influences their decision making. So cultural humility is foundational to understanding that folks are individual and we will benefit from understanding how they move forward. So the National Institute on Health defines cultural humility as a lifelong process of self-reflection, self-critique, whereby the individual not only learns about another's culture, but one starts to examine our own beliefs and our own cultural identities. So self-reflection is what's warranted here, it's what is encouraged. And so the idea here is to understand what our own personal philosophies are for us as a person, for us as professionals. You know, what is it that we believe in? When you're able, the fascinating thing about bringing your awareness up, about acknowledging and doing that practice and recognizing and acknowledging your belief system, it is more likely that you're able to kind of acknowledge that and not let it be part of the lens that you use to filter through what you believe the person is about, other person that you're working with. So self-reflection is really about um, lifelong learning. And lifelong learning has to do with being able to understand and learn about the other person. The patient-focused interviewing and care has everything to do with how we engage that individual and what their perspectives are on their current situation, what the challenges are like, what are their resources, what is their understanding of their current situation. And so engaging in the continuous self-reflection is key, but it's not enough also for us to think about our own values. It really is a practice of being able to be aware of what issues are affecting that individual. Are there sometimes with some of the individuals that we have in care, the historical awareness has a lot to do with the realities that certain community members have had of different oppression and perhaps bias in their own world. Community-based care and advocacy has been essential to cultural humility in terms of being able to collaborate with other resources and provide the the appropriate services to according to the needs of that individual. Even if you don't have the capacity within your own setting, you can partner and have some at least linkages with other community resources to be able to provide that comprehensive person-centered array of different services for an individual. So cultural humility really encourages us to get to know the other person, find out what is it that's so important to them, how do they see their situations. So the care that we give them in there while they're in residential care, that can help them understand how they can play an active part. So how you engage, how you initiate that rapport with the individual is really a key factor here. So person-centered care means treating residents as equal partners in the business of healing. It is personalized. It's coordinated and enabling because we are seeking to have them to actively participate in their processes. You have the clinical, you have the physician, you have nurses, you have physical therapists, you have nursing nursing home assistants. You have an array of different professionals within that setting that all can recognize that that person works, looks and thinks about things in a particular way, and they can engage that individual perspective, that resident's perspective in how they provide the services to them. So, and that can, what that can do is help build their motivation to be more active in their wellness process. So we want to recognize when it comes to substance use disorder that the capacities of people with SUD to actively participate in improving their own health in their own health process can help increase treatment adherence. And so here, I'd like to provide you with an opportunity to hear, to see this video and hear it and see what you think about it. We'd love to hear, to understand what your feedback on this.
Person-centered care recognizes that a person is the most important part of their care. That's why person-centered care encourages nursing home staff to partner with a resident to make decisions about the person's care. By building relationships and thinking people first, staff treat residents with the respect they deserve. Nursing home staff can practice person-centered care by creating individual care plans for residents. Each day, a care plan guides the staff that works with Ms. Durham. Overall, the plan focuses on Ms. Durham's social and emotional life just as much as her physical health. This plan indicates to nurses that Ms. Durham likes to shower in the mornings, but recently, Ms. Durham has been reluctant to shower. Ms. Durham's plan is constantly evolving. Today, she's updating it with the help of her daughter and an ombudsman. Staff treat Ms. Durham as a partner in this process. Staff don't only think about the risks of changes, they discuss how changes to Ms. Durham's care plan can improve her life. Staff encourage Ms. Durham to talk about new things she wants to try. Problem solving is also a key part of care plan meetings. Staff address Ms. Durham's reluctance to shower. By talking with Ms. Durham, staff find out she gets cold when she showers. So staff update Ms. Durham's plan with a solution. Staff will let Ms. Durham test the water before getting in. They'll also make more towels readily available for her to use to keep warm. Later, the team follows up with Ms. Durham to ask what the nursing home team can do better and if the care plan is working. Ms. Durham says she's no longer hesitant to shower because of the changes to her plan. Staff then let other team members know about Ms. Durham's feedback.
So I'm curious here to know what your feedback on this is. Because when you think about it, let me stop here for a second. When you think about it, think of the difference between engaging a resident in their own healthcare plan, asking them about the challenges or things that you may see as a nursing home staff person, that you can see that they're not necessarily very happy about eating certain foods. They're not necessarily very happy about the timing of certain say physical therapy. So just imagine when you do include them and include their feedback, their perspective. You have a conversation with them about the changes or the challenges in their care, then you have a collaborative opportunity to together be able to work around it as the video showed. Now consider, for instance, like say you have a resident in care and a new medication has to be administered. Instead of just providing them and telling them and giving information that this is going to, we're going to change this medication to this medication, as opposed to being more directive, we can be more collaborative. You may consider having a conversation before the new medication is administered, being able to provide the information, get their feedback, provide them the benefits of why the physician wants to change the medication, and provide and the opportunity for them to allow them to remind them that they have a choice on whether or not they want this new medication to be provided to them. Just being able to empower them with a choice, that autonomy, can be so helpful in their active and building their receptivity about actively engaging in their wellness process. And so whether or not they agree with the new medication, just being able, so that gives them a choice that you can work with. If you want to give them the benefits, get their feedback, as opposed to just telling them, because then it's more of a directive approach, and it doesn't necessarily enhance outcomes sometimes with some of our residents, because some of our residents may be in long-term care, may be in very debilitated condition, and their active participation can enhance those outcomes. And so that's part of what person-centered care can do. And so when we engage folks and when we engage residents in care, one of the things that we've learned over time is how we can consider, first of all, the preferred language. It's not enough to know just enough English or comprehension just to get by. If there's a language communication issue, we really should either offer the opportunity to get someone who can translate, or be able to at least understand what their preferred language is, and if the staff can speak that language, that is appropriate, asking someone their preferred language, because that also is key to you being able to communicate very clearly, information about the care, information about the medication, information about aftercare. And so that is particularly important. And for folks whose language really depends a lot on, like, collectivist societies who really depend a lot on the context, like Hispanic communities or Latinos and Latinx, or the Asian communities, or other communities where context makes a big difference in understanding. And so preferred language, asking for preferred languages is critical. We also know that there are certain ways of engaging in conversation that can speak to using certain communication skills very strategically. Very often, we can have a conversation with an individual where we just elicit information and hear what they have to say. We can invite them to be part of the conversation and provide a lot of information, which could be insightful for you since you're providing the care. So open-ended questions can help invite other people to engage in conversations. Affirmations is a great way to keep acknowledging someone's strength and help them feel like you hear them, like they are actually important enough that you are present with them. And it could be very empowering for them. And so it is also a great way for you to hear information that you may not necessarily have available to you unless you elicit it. And so effective listening and summaries are also skills that we can use to engage individuals in that conversation. And I always keep saying conversation because it shouldn't be a dialogue. It shouldn't be just a simple interaction. For the resident, it should feel like a conversation with another trusted individual, with someone in their life who they more commonly just have a natural, non-judgmental, very comforting, everybody's perspective is included and important conversation. And so the ORs, or open-ended questions, affirmations, reflective listening, and summaries can be really effective in helping us develop that trusting and safe atmosphere for a resident to be more forthcoming and transparent with us. So in terms of person-centered care, being other person oriented, which is cultural humility, which is the foundation of what person-centered care is, being able to understand the residents' perspectives, what their needs are according to their perspective, what are their desires about what they're hoping their care can look like, what do they eventually want to achieve. All that can provide you insight in how you provide them care. The other thing to consider is the person's culture. What's their viewpoint? What's their capacity? What are the resources? What are the philosophies that they adhere to for themselves? It's not enough to know whatever community that you come in, whether it's, no matter what community you're speaking to, it's that individual. What is it that helps them in their life? What does their day look like? Where do they have support resources? All that can be helpful and insightful for the care that you're providing in the facility, as well as it can also as well inform the aftercare plan. Communication, preferred resident language, and I spoke to that already. Using recovery-oriented terms, like staying away from substance abuse and saying substance use disorder, or maybe substance misuse. Many people, you have a lot of folks who are in your care are from the older generation, over 65, and people use substances not intentionally to feel a high, but many times to mitigate medical or pain issues. And so may not necessarily understand that they may be impacting their health and maybe their trajectory or the way the level and the frequency of what they're using may put them at higher risk of a substance use disorder. So you have an opportunity to use recovery-oriented terms to be able to provide information and help someone consider that maybe some of the things that during their life can use a little tapering, can use a couple of tweaks here and there. And so collaboration, partnering with the residents to make informed decisions, that's especially helpful. And regarding substance use and other potential recovery supports. What I want to leave you with is this, person-centered care for nursing home residents, when it's regarding substance use, actually person-centered care works for absolutely any kind of care that you're giving. It's not just substance use, but it's so effective, and the research has been showing how effective it is to use that approach with someone who may have substance use problems that can be exacerbated, that can increase, that can really cause some who may be putting themselves at risk, but are not necessarily experiencing the consequences yet. So if you are in a critical point here where you are the person of opportunity who can engage the resident in understanding health issues, and how substance use can impact their particular health issues, and how they use certain medications, and how that can increase the risk of the health issues. So you're also able to provide the pros of particularly different treatment options if they're at a point where, say, they can benefit from an actual assessment and potential diagnosis. We use brief interventions and person-centered care, person-centered brief interventions with individuals when we screen someone for substance use and try to have a conversation around reducing or eliminating the overconsumption and mitigating the impact of the substance use. So that can include having a conversation of the pros and the cons of potential different treatment and recovery support resources. So support residents in their decision to seek substance use disorder treatment or not. Potentially help inform and provide harm reduction options. And I'm saying or not because not everyone meets the criteria of substance use disorder. Many people are consuming at a risky level, are misusing medications, or maybe using alcohol in ways where putting them at risk for a substance use disorder. As a matter of fact, for every person that does meet that criteria, there's typically 4 to 6 people who are consuming it at risk levels and are actually experiencing consequences to their health conditions and in other psychosocial domains of their world, due to the level of consumption. And so when you are able to engage in a person-centered way, when you're able to engage in and have a conversation with an individual where they're not being judged and they're being provided information that's very tailored to their specific conditions to their specific world, you have a higher likelihood of increasing their receptivity and being able to motivate them to actually consider to taper or do something different about their level of consumption. And so the idea here is to support residents to implement residential decisions regarding the substance use. It's also a great way to consider how to engage folks and help them think about how they can better augment all that care that you're providing and how they can take a certain amount, they can actively take certain responsibility to be able to do more for their own wellness process. And so that can be hugely, hugely important. And so, so person-centered care, it makes you the trusted person and the person more likely that they will go to. It also helps you understand the different mitigating factors that can affect someone's thinking in terms of why they don't necessarily like how when they go to have a meal, or like you saw in the video, like the taking of the shower can be perceived as a non-compliant issue. We want to see it as a person issue and be able to ask and work around the desires or the wishes of the individual. That can enhance their participation in their process and augment what you folks are doing. And all that hard work that you're doing, it really can increase their capacity to also, add to their wellness process. It just makes it a happier outcome for them, a healthier outcome for them, and a likely happier atmosphere for you folks providing that care. And so with that, I'm going to ask if there are any questions at the moment.